Hey guys, am I audible and visible? If so, say me a hi and hello. A very good evening, everyone. I hope, good evening, Nayak. I hope I'm audible and visible. Great. Hello, Suresh. So, the trending news for the past couple of days is India has been reported as the cancer capital of the world, right? I'll dig into the details of it from the original article and put a post soon. So, since that has been in the news, let's have a discussion on the clinical diagnosis of cancer. Whether it's real or not, is India really the cancer capital of the world or not? I'll definitely let you know very soon, because statistics are something which is partly hidden the truth from us. And yeah, something what came in the article is definitely true. So our goal in today's lecture is to have a clinical diagnosis on cancer, or in other words, entire diagnostic protocol or approach for cancer. If you have a long answer question of saying how do you approach cancer diagnosis and the prognosis, this will help you to streamline a lecture for you, and it'll easily be when you go to your final year also, you know, okay, this is what I have to do step by step to in order to diagnose cancer, right? So whenever you have anything which says that how do you diagnose any condition, I want you to split into phases. First, obviously, is in clinical examination. That obviously should be there, which includes your symptoms and signs. If you started going to your clinics, I'm sure you know what is the difference between symptom and a sign, right? What do you think is the difference between symptom and a sign? Anyone? Your clinics have started? If your clinics have started, you should fairly know the difference between a symptom and a sign, right? Symptom is what patients complain with, right? Sure, I should look into it. Whatever the patient says is a symptom. Like I'm feeling a headache and my head is aching, that's a symptom. Sign is something which a doctor elicits. So I'm going to examine a person and say that, okay, there is a thick artery here. That's a sign, right? Symptom is what the patient says. Sign is something what the doctor elicits and finds out. There's a neck rigidity. I know it's a sign, right? So there's a symptom and sign. That obviously the first thing, clinical examination. Then obviously your lab diagnosis comes into play. Okay, so these are the two broad categories by which we can diagnose any cancer. Perfect, right? That whatever they said is the right answer, right? So whatever once I have a suspicion clinically, I have to confirm them. In the lab diagnosis also, I have multiple things. In the lab diagnosis, the first is going to be histopathological examination, just a biopsy or an FNAC, or let's say a histopathology or a cytological examination. There are multiple different types of tissue what I can see for a cancer patient: FNAC, your fluids, or a biopsy. Then I have something called an immunohistochemistry or special stains. So these are special stains which help me to say, okay, this is the subtype of cancer what the patient is having, right? Next, I might slowly move into genetics. So under lab diagnosis, I have multiple subtypes or serological studies of tumor markers. So these are all the ways by which I can identify a cancer in an individual. I have a history, symptom and sign, and lab diagnosis. I have tumor markers, which is a blood test, biopsy, which is a tissue which I obtain from the patient, look into the microscope. Same with cytology. Yes, FNAC stands for fine needle aspiration cytology. Under the bigger spectrum of cytology, it's an aspiration cytology. It comes under cytology. And I have immunohistochemistry or a special stain. I can do a genetic markers if required, and also have tumor markers for diagnosis, right? These are the ways or outline by which I can diagnose a cancer. First, let's go to clinical diagnosis. So let's assume you are having a patient with a breast cancer or a colonic cancer for the matter, or any cancer for the matter. What comes to your mind first? How do you diagnose or how do you suspect a person? Okay, this person is most likely suffering from a cancer. When will you suspect? Most of the cancer is a mass lesion, right? They present as a mass lesion, right? Mostly any cancer for us, clinically, the diagnostic point is a mass lesion. Be it a breast, be it in a leg or my hand or my toe, anywhere in the body, it is going to present as a mass lesion. Mostly, whenever the mass is hard, think of a cancer. Whenever the mass is immobile, think of a cancer. Whenever the mass is stuck to an adjacent tissue, and instead of saying like let's take a skin mass, if it's stuck to the skin epidermis, then it's most likely malignant, right? Immobile mass, hard mass, or it is stuck to any underlying tissue because it's infiltrative, right? Cancers are infiltrative. So when I have any of these findings, I think of a malignant mass. It could be benign, but I generally think of a malignant mass if it has all these findings. A hard mass in the lump, which is not moving across. Uday, generally, if it's tender to touch, what do you think your take is? If something is tender, you think of an infectious etiology or a cancerous etiology. Most of the cancers, since you've taken tender, they are non-tender and they are painless. Okay? Tenderness is a sign which is elicited by the doctor. I think of an infection whenever it's a tender. Generally, cancerous mass will not pain. Cancerous mass will not have tenderness also. Tenderness is something which I elicit. Pain is something which the patient says, symptom and a sign again, right? So these are things for me to think in terms of a cancer. This is true for any superficial mass. For any superficial mass, these are all the findings which I'm going to look for. But there are a few other findings as well. If you remember your physiology exams when you read your physiology, you must have heard about something called visual field defects, right? Visual field defects which happens in your because of the compression of the optic chiasm or the optic tract, right? There is a possibility the mass lesion can present differently, right? So the presentation could be due to some other findings of the mass lesion also. Either mass can cause compression symptoms. That's a very important presenting way of most of the intracranial masses, right? Most of the intracranial masses, I cannot see them, right? I cannot see a mass inside the skull. It will not be visible. But the same mass can obstruct or press on the optic chiasm. Pituitary adenoma can cause hemianopias and everything. I have a mass in close to the ventricles. It can obstruct the ventricles, can result in a hydrocephalus. These are compression symptoms. The masses which I cannot see, they can compress on some organ and I can elicit symptom out of it, right? The best example for this is pituitary masses, a pituitary adenoma. Definitely this can compress your optic chiasm or an optic field or an optic nerve, and they cause an optic visual field defects. Based on the location of the pituitary lesion, it can cause hemianopias, it can cause chondroitinopia, different types of lesions. You would read about that when you come to ophthalmology in the next year, right? Next, not just this, I can give one more example. You have an ventricular mass. I'm talking about inside the brain ventricle, not the heart ones. Intraventricular mass in the brain, they can cause obstructive hydrocephalus. Hydrocephalus, as the name says, it's a very big head. You must have seen advertisements coming on this millap and keto.org for donations. Kid with a huge big brain. Possibly could be a mass obstructing the drainage route of the CSF that blocks the ventricle and the ventricle becomes enlarged. We call it hydrocephalus. This could also be a compression symptom, right? Third way of presenting in a tumor can be due to the secretion. The mass can be functional. Okay, we'll just take pituitary again for an example. There are many things you can have. We'll leave pituitary. We'll move outside of the CNS for a time. Let's say I'm having a tumor from the beta cells of pancreas. What do you think they will secrete? A tumor from beta cells of pancreas? Just example, I'm going to name the tumor as insulinoma. Beta cells of pancreas can also have a tumor, malignancy. I call them an insulinoma. They will secrete obviously insulin. So how will the patient present? The patient presents with hypoglycemia, right? Because the patient will have abundance of insulin. So obviously the insulin will have an effect. The patient will present with hypoglycemia. This is an effect of the tumor function. I can present just as a mass. You can compress the normal parenchyma, or I can present as a function of the mass, right? Just one more example. Let's take you have a tumor which is prolactinoma, which happens from the pituitary because there are prolactin cells there in the posterior pituitary, right? I have a prolactinoma, a tumor from the pituitary. How do you think the patient will present? Prolactinomas. A very classical presentation. How do you think the patient will present? Having a prolactin secreting tumor, they present with galactorrhea. That's a classical symptom, right? Because prolactin is helpful for the milk secretion. If you have a history which says a non-lactating, non-pregnant woman, there is white discharge from the nipple, that's milk discharge. Think of a galactorrhea. Because lactation happens only after pregnancy, after childbirth. If there's no childbirth history, but still the woman is lactating, the problem is pituitary is having a tumor from the prolactin secreting cells, which is having an examination, right? That's the presentation. So clinically, there are three ways of presentation. Just the mass lesion could be a compression symptom or could be a functional symptom, right? And I have a huge list of this thing called PNS. PNS stands for Paraneoplastic syndrome. Okay? This can come in a viva. They may just ask you what is a paraneoplastic syndrome. Para is not exactly the same, it's close or surrounding. That's what para means, right? Paracrine, surrounding, in and around, right? So paraneoplastic syndrome by definition means they are symptoms or signs. We have given three groups of symptoms, right? It's not related to the three groups, that's what. Symptoms or signs which is not related to the origin of the tumor, origin or functionality of the tumor. That's what I call it as paraneoplastic syndrome. Simple. A tumor from prolactin can cause galactorrhea. Definitely a tumor from beta cells can cause hypoglycemia. Can an ovarian tumor cause hypoglycemia? Yes or no? Ovarian tumor cannot cause hypoglycemia normally, right? So if you have an ovarian tumor which causes hypoglycemia, I call them a paraneoplastic syndrome. That's not related to ovary at all. If you have some other tumor causing galactorrhea which is not prolactin secreting, I call it a paraneoplastic, right? At least few examples for them. Hypercalcemia is the most common paraneoplastic syndrome. This happens in squamous cell carcinoma of lung. This happens in breast cancer. It's the most common paraneoplastic syndrome, right? That's hypercalcemia. Second, Cushing syndrome. So Cushing syndrome is the most common endocrinopathy in case of a paraneoplastic syndrome. And Cushing syndrome is seen in small cell lung cancer. That's one of the commonest tumor which can present with Cushing syndrome. Okay. Right. So these are paraneoplastic because small cell lung carcinoma has nothing to do with ACTH secretion. By some mutation or some abnormality, these secrete ACTH like peptides. So it ends up in having Cushing syndrome. The same reason, squamous cell carcinoma due to some abnormality secretes PTHRP, PTH related peptide like a parathormone, right? Okay, that's what I call it a paraneoplastic syndrome. So squamous cell carcinoma lung, some of the time, not all of the squamous cell carcinoma, some of the squamous cell carcinoma of lung, they secrete a substance called as PTH related peptide, something like a PTH. So once that is there, obviously can PTH cause hypercalcemia? They can, right? So I call it a paraneoplastic syndrome. I'm not able to explain why yet. Maybe some of the molecular mutations in the squamous cell carcinoma is making them produce a protein which is like a PTH, so they present as hypercalcemia. Like 1-hepalindo syndrome. The main mutation is VHL. So it increases erythropoietin. So polycythemia can be a problem, right? So it's not related to the structure, the anatomical location, or the function of the tumor cells. I call it a paraneoplastic syndrome. That's what we call it, right? Okay, these are group of ways by which the patient can present to us. So the first chunk of diagnosis is undoubtedly clinical diagnosis. I can have a high index of suspicion with clinical diagnosis. In addition to this, radiology can definitely be a part. Radiologically, I can definitely find an ultrasonogram or CT scan which can exactly say cancer or not, right? Then let's come to lab diagnosis. In lab diagnosis, what all can help me? In lab diagnosis, like I said, the first chunk is tissue diagnosis. I'm going to look at some tissue using that biopsy or an FNAC in the microscope, right? We already know if there are 4 features of dysplasia: pleomorphism, high NC ratio, mitosis, loss of polarity. I think of a cancer, right? In tissue diagnosis, I can have a biopsy where I'm going to take a tissue and I do an histopathological examination, HP examination. I have one more type of tissue diagnosis called as cytology. In this cytology, I'm going to divide them into 2 major groups. The first group, I'm going to call them an FNAC, because I told the expansion recently, we call them a fine needle aspiration cytology, right? Have you put IM injections? How many of you injected anyone like IM injections? Intramuscular injections. Have you given? There'll be a blue color needle in the intramuscular injections, right? That's what I use here. That's why I call them fine needle aspiration cytology. Okay. So fine needle aspiration cytology is done for quite a few conditions in the body, especially one place, that's thyroid. In thyroid, I cannot take a biopsy. In thyroid, the mode of diagnosis is only FNAC. I'll give you a simple example. Let's take you are taking biopsy of any random organ in the body. Will the organ bleed? Yes or no? I'm taking a tissue from here. Will this part bleed? It will definitely bleed, right? So if it bleeds, what's the first step for achieving hemostasis? You compress the area, right? But here, thyroid is in such a location. If I'm going to put a deep tissue for a biopsy and take a chunk of tissue, I cannot compress this area. So there is only one way. Put the patient under anesthesia, cut it open and take a tissue from thyroid and suture it, or go for a fine needle. That's why I prefer fine needle aspiration. With a tiny needle which I use for intramuscular injection, I prick, take the tissue outside, look into the microscope. Because it's very difficult to achieve hemostasis. And I'm sure from anatomy, you know, thyroid is a very, very vascular organ. Right? It's a very vascular organ, so I can't do it. That's one side, fine needle aspiration cytology. I have one more method of cytology called an exfoliation cytology. So from the term itself, I can understand something. Exfoliation, which means the cells fall down. It's exfoliation cytology. Cells automatically fall down, right? Can I say every day when you take bath, my skin falls? Obviously, right? So skin falls automatically. I'm looking at the cells which are already shed and giving a diagnosis. One of the famous exfoliation cytology is pap smear. Where do we do pap smear? Which part of the body? We use it for cervical cancers, right? So we use it for cervical cancers. Cervical cancer screening, right? What happens in pap smear is the ectocervix is also a squamous epithelium, like skin. Skin is also squamous, ectocervix is also squamous, right? So when the same squamous epithelium is there, they will shed. That's a property of any squamous epithelium. So what I'm going to do is I'm going to use a instrument called as an IR spatula. I'm going to take the shed cells. It's already shedding. I'm not pricking it, so very less invasive. I'm not even putting a needle. I'm not taking a chunk of tissue. I'm looking at the cells which are shed. That's why I call it an exfoliation cytology. It's pretty much very, very less invasive. It's extremely useful for cervical cancer screening, right? So these are the ways by which I can get a tissue. Could be a biopsy, very good, easy for me. Could be an FNAC, could be an aspiration cytology. That's my first start, right? Second thing for us is stains. I have special stains. I have IHCs. IHC stands for immunohistochemistry. The positive color in IHC is brown. Just remember that anywhere IHC, positive color is brown. And when I have brown color, it's due to a stain called as DAB. Diaminobenzene. This came once in an INICT exam. Diaminobenzene is the reason for the brown color in your immunohistochemistry. Brown color is the positive color and diaminobenzene is the reason for the brown color. Fine. Okay. Now let's see what is the use for this immunohistochemistry or a special stain. So when I take an immunohistochemistry, there are multiple use cases. One, for an unknown metastasis, I will be able to tell the primary tissue of origin. I'll give you a simple example which you can easily relate. If you have a cervical lymphadenopathy, right? Is there a possibility the tumor could have come from your oral cavity? Yes, no. Definitely yes, right? Could have come from oral cavity. Is there a possibility the tumor could have come from the lung? Yes. Esophagus, upper part, cervical, yes. Thyroid, yes. Mediastinum, yes. So a cervical lymph node can drain from multiple parts of the body. So if I take a cervical lymph node by the biopsy, I can use this marker and say, okay, this is probably from lung, probably from your salivary gland, probably from your thyroid, right? So it tells me the primary tissue of origin. If it's positive from lung, I can definitely look at the lung and go for the further investigation, right? So unknown metastasis, it will tell me the primary tissue. That's first. Second, it can help to assess prognosis. It's a prognostic marker in quite a few areas. Simple example, you have a breast cancer, one of the commonest cancer seen in the world. So breast cancer, we do three markers, ER, PR, HER2 new. These are the three markers we do for breast cancer. If a breast cancer is ER negative, PR negative, and HER2 negative, a breast lesion is negative for estrogen receptor. What do you think normally will they be positive or negative breast tissue? Will a normal breast tissue be positive for it or negative for it? It's estrogen receptor. They will be positive because breast responds to estrogen. After menarche, breast grows because of the receptors, right? So if we have all the three negative, this we call it a triple negative cancer. This triple negative cancer will definitely have a worse outcome, worse prognosis, because this cancer is not behaving like a normal breast tissue, very poorly differentiated. So normal breast tissue is ER positive, this cancer is ER negative, PR negative, so it is very worst differentiation. I call it triple negative cancer. So it helps me for an unknown metastasis. It helps me to know the prognosis of the patients, and most of the time, for me, it also helps me to confirm the subtype, confirm which subtype it is. It'll definitely help us to confirm subtype. For example, I know it's a lung cancer. Lung itself has like 10, 20 different subtypes of cancer. I need to do markers and say, okay, this is most likely this form of cancer. To tell subtypes, I can use the immunohistochemistry. Again, a use case, fine. Next is third, like I said, I do have genetic studies. Okay. So genetic studies is also very useful for us in multiple aspects. It's not always like I'm going to use it for diagnosis. Sometimes use it for diagnosis for sure, right? One, it's might be useful for diagnosis. We did read lots and lots of proto-oncogenes and tumor suppressor genes when we were in the first half of the neoplasia lecture, right? So if I say a tumor is positive for retinoblastoma gene, I could think of a retinoblastoma or osteosarcoma. It will definitely help in diagnosis. Best example, CML, Philadelphia chromosome. That's a genetic study, right? Translocation between 922. I think of a CML, chronic myeloid leukemia. It can be helpful, very helpful in diagnosis. Second, again, it will be useful for prognosis. Same way, I have few markers. When we come to hematology, we'll read huge amount of markers. Okay, this translocation positive, good prognosis. This is positive, bad prognosis. It can easily tell me the prognosis, right? Third, it can give the risk of hereditary cancer. Okay? This is very important and this has been used very much in the recent days. Which cancer or which gene did Angelina Jolie check for? Which gene did Angelina Jolie check for? The BRCA, right? Breast cancer genes. So if a parent has breast cancer in around 35-40 years, there's very high likely chance that it could be inherited. So if there's a female in that family, we test for the BRCA1, BRCA2, BRCA1, BRCA2 gene and say that, okay, you are also at a risk of cancer. So I can easily predict hereditary cancers, and obviously genetics can be used too for new drug development. We have lots of targeted therapies coming every now and then. Definitely genetics play an important role in the drug development, right? That's the use case for genetics. Last but not the least, you have to definitely complete a little bit word about tumor markers. Though tumor markers is not very much important for me, just a little bit of word. So tumor markers are blood test. I don't take any tissue here, you take a patient's blood. Tumor markers are not specific at all, right? They are sensitive tests, they are not specific, they are not diagnostic, they help in diagnosis. Tumor markers alone is never diagnostic. They will help me to suspect, that's all. The path taken, anemia practical slides. I'll be starting RBC disorders from Wednesday. I'll definitely include whatever things we read with the practical slides, fine? Okay. So it's a very sensitive thing, but it'll help me in diagnosis. It'll never be the sole thing which will depend on for diagnosis. It'll definitely help in diagnosis, right? Few tumor markers for you to remember. Alpha fetoprotein is a marker seen in liver tumors and also seen in non-seminomatous tumors. Okay, that's one. HCG. Where have you heard about HCG in your physiology? Human chorionic gonadotrophin. Placentas, right? It's seen in choriocarcinomas. In case of a choriocarcinoma, so beta HCG or HCG is very highly elevated, right? Which slides path taken? I think you pinged me on Insta also. I missed it. I wanted to reply to you. I missed it. Which slides do you want? Maybe I'll put a reel on that for you to just to have an orientation. Right? I don't have it right now, so I'm not able to complete that. Fine. So there are like CA 125 is a very good marker for CA ovary. I'm not saying that it's only elevated in CA ovary. In endometriosis also it will be elevated. But if it's in thousands, CA 125 in more than 1000 or 1000 time increase, I think of a carcinoma ovary, right? CA 99 in pancreatic cancer. All these CA I want you to remember. CA 153, it's in breast cancer. Okay, that's one. And last but not the least, just one more finding. This is very important. PSA in prostate cancer. There's a huge table in Robbins. In that, except for the last column rows of the table where they discuss about the aneuploidies, P53 neuron, that's not practically involved. Anything above that is practically important. Above whatever is there in the CA 125 and above that, all of them are practically useful markers. We'll read them a little bit here, and when you go to systemic pathology, we'll definitely read a little bit more about it. Fine. Okay. So if you have a question on the lab diagnosis of clinical diagnosis of cancer, first clinical examination, then lab diagnosis. In clinical examination, symptom due to the mass, symptom due to the compression, symptom due to the secretion or the function. So once you have completed that, paraneoplastic syndrome, define paraneoplastic syndrome and write a few words and few examples about it. There are many more examples in Robbins, and we have covered many more in the essentials batch. Add on to them as well, right? And when you come to lab diagnosis, tissues. First tissue can be biopsy, can be cytology. Biopsy has FNAC, pap smear. Given examples, one for thyroid, one for your cervix. Then I can have special stain, helps me to know unknown diagnosis, helps me to aid the prognosis and to confirm the subtype of cancer. Then genetics, few use cases, and finally end up with pap smear, right? So cancer is always a multi-system diagnosis. You can't just like that do one test and say this patient suffers from a cancer. Radiology is very important as well. That also will help you to tell the extent of the tumor and the presence of the tumor, fine? That's about your clinical and lab diagnosis of cancers. So we'll call it a day for today's lecture. Okay, the path taken, all the very best for your exams, upcoming exams. Do ping me. I'll definitely guide you in the best way possible in few slides. Fine. Thank you and bye.